Okay, hi. Can everyone hear? Can you guys hear me? Okay. Okay, awesome. So I'm gonna start this off. Hi everyone. My name is Jessica T, a 2017-2018 Fellow for Life from Chicago. I now reside in Tulsa, Oklahoma, and have been involved with the chapter here, especially in planning the Leadership Summit this past November, which a few of you attended. At the end of the summit, there was a lot of interest in maintaining connections and engagements with members of the Schweitzer community at the national level. The webinar series was suggested during the brainstorming sessions, so we are excited to see the idea being put into action tonight. To give you a sense of who is in attendance tonight, we have 36 fellows, fellows for life, and program directors from 10 different chapters: Alabama, Chicago, Columbus, Athens, Dallas, Fort Worth, Detroit, Houston, Galveston, New Orleans, North Carolina, Pittsburgh, and Tulsa. Thank you all for joining us for the first national Schweitzer webinar, Becoming an Immigrant Welcoming Healthcare Institution. Before we get started, I have a few announcements. Please call in on your phone instead of using your computer for audio. In your control panel, under audio, you can select phone call, and it will give you the phone number, access code, and PIN number to call in. This would help minimize sound issues during the webinar. Our speakers has uploaded a resource sheet under the handouts pane in your control panel. We will be having a Q&A session at the end of the presentation. You can type in your questions at any time during the webinar, and we will address them at the end. This webinar is being recorded, and a link to that will be sent out in an email. Finally, Schweitzer Fellowship recruitment is in its last week. If you know someone who is or would be interested in joining the next cohort of Schweitzer Fellows, please encourage them to submit an application to the appropriate chapter by February 1st. Yeah. All right. Now I would like to introduce our speaker for this evening. Padraic Stanley is a 2014-2015 Fellow for Life from Chicago. His Schweitzer project was completed at the Latino Organization of the Southwest, where he ran groups and psychoeducational workshops for Latinx youth and provided individual counseling for undocumented, uninsured community members. He graduated with his master's in social work from Loyola University Chicago with a concentration in leadership and development with a certificate in migration studies. He is employed at Rush University Medical Center in Chicago as a program coordinator for health promotion and disease prevention programs and co-chairs the Institutional Task Force on Immigrant Health. He is also a weekend inpatient case manager at Mercy Hospital, an instructor at Malcolm X College for the Community Health Worker Program, an active member of the International Association for Social Work with Groups, and a mentor for the Chicago Area Albert Schweitzer Fellowship. Padraic will be speaking on his experiences with instituting immigrant welcoming policies at Rush University Medical Center and sharing strategies on how you can do the same at your workplace. Padraic, thank you for presenting tonight.
All right, thank you, Jessica, for the introduction. So I will go ahead and get us started. So as Jessica said, I'm going to have you all on mute for a while, and so, but we'll open it up for question and answers towards the end because we do have some case studies and everything. So I do want this to be a more participatory webinar, as participatory as a webinar can be. So, if you feel comfortable talking over the phone, then we'll have that option, but you can also type your questions as well. So, so as the title says, I am Padraic, and that is the work that I do here in Chicago at Rush. But then also Rush University Medical Center is part of a huge collaborative of healthcare organizations in Illinois that are focused on making our institutions more immigrant welcoming through the Illinois Alliance for Welcoming Healthcare. So a lot of, the expertise is, not only just from me, but also from lots of other people working at healthcare institutions around the Chicagoland area, as well as plenty of undocumented community members, community organizers, and activists that have all contributed to this kind of wealth of knowledge that you guys are going to get today. And a really special shout out to the cohort of Schweitzer Fellows that I have had the pleasure and opportunity to mentor this year, who have really worked on developing the handout that you all have available. So major props to them as well. So, all right, so we're going to start off today just kind of giving you a basic premise on how the fear of immigration enforcement is affecting healthcare and how it's affecting immigrant access to immigrants accessing their healthcare. And then we're going to follow up specifically with the barriers that immigrants face in accessing healthcare. So we're going to do that with some clinical case examples. We're going to follow that up with major guidelines and projects, guidelines and projects to becoming a welcoming healthcare institution. Then go into the case studies, which we'll do as a group, and then we'll open it up for questions and answers. So to start it off, Immigration and Customs Enforcement is known as ICE, and that's how I'll be referring to it for the remainder of the presentation, but ICE stands for Immigration and Customs Enforcement, and they have had what's called a sensitive locations policy in place. It's not a law, it's not, something that they absolutely have to abide by, but it says that Immigration and Customs Enforcement is not allowed, should not operate in healthcare institutions, educational institutions, churches, protests, or during natural disasters. However, unfortunately, since the new federal administration has taken hold, we've actually seen issues of immigration enforcement happening at every single one of these locations. So it's kind of been obvious that, obviously there are more ICE agents and more ICE offices that are more rogue than others. However, we've seen, unfortunately, that there's been a general disregard for the sensitive locations policy, but thankfully, not to the point where it's kind of created widespread chaos. But unfortunately, it has been an issue. Going into the fear of immigration enforcement, it does really affect how patients are accessing their care. So there's been a lot of research out there that's showing that it's decreasing how often immigrants, not even just undocumented immigrants, but how all immigrants are decreasing their primary care and preventive care. It's decreasing their access to chronic care management. So even services that people actually do qualify for, they are still not accessing. And then, for example, decrease in accessing benefits that they do qualify for. For example, in Illinois, anyone under the age of 18, regardless of your immigration status, can qualify for Medicaid through what we call the All Kids program. However, what we're seeing is that there's a decrease in enrollment in All Kids because there's this fear of retaliation, fear of accessing these benefits if that will be held against them. And then also we're also seeing is that undocumented parents who have U.S. citizen children are also avoiding applying for benefits for those children because those parents will have to put their information on there and they risk the backlash. So essentially it's creating a lot of problems for the immigrant patients that we serve. And so a lot of healthcare institutions, particularly the ones in the Illinois Alliance for Welcoming Healthcare, but not just us, have been thinking about what we can do as an institution to help address those concerns. So unfortunately, the reality is that undocumented immigrants do not qualify for many of the services that they depend on. And I'm sorry, I also have, in my work, I focus a lot on older adults. And so that's kind of when you work in medical social work, it oftentimes is a focal point. So I'm sorry that older adults is there, but it is, I forgot to remove that, but it still holds true. But undocumented immigrants, regardless of what people may say, do not qualify for Medicaid, Medicare, marketplace insurance. And this and them not being able to apply for these insurances impacts their eligibility for long-term care, nursing homes, rehab, preventive care, etc. They're not eligible for public or subsidized housing. They're not eligible for home health. They're not eligible for homemaker services, and they're not eligible for food stamps or any sort of other public benefit. So let's look at some clinical case examples, kind of given the reality of what undocumented immigrants are facing are facing in this country. So one example that we worked with through the Immigrant Health Working Group at my institution, so our Immigration Health Task Force, was Mr. and Mrs. G. So they were a couple visiting family out of state, and unfortunately they had a horrible car accident. So Teresita was the wife, and she ended up being on life support with absolutely no hope of recovery. But unfortunately, without Medicare or Medicaid, there was no long-term care facility that would take her. So they were at this location totally out of state, totally far from their home and their family, and no hospital would institute an institutional transfer to get them closer to home. And unfortunately, no long-term care facility would actually accept them because they were uninsured and undocumented, and there was no hope of getting any sort of coverage for her. So Rush came together. Our chief medical officer and our chief of palliative care came together to initiate a hospital transfer. So basically we said, Rush will cover all the expenses of the and this the home hospital said, we will cover all the expenses of the transfer if you will just take her. And so we initiated this transfer, and we had to utilize our preferred contract relations, and it took a lot of negotiations with a skilled nursing facility. It was actually with an acute care long-term, an LTAC, long-term acute care hospital. It took a lot of negotiating to get them to accept the patient for 45 days in their facility, and that's the most that we could get out of them. But thankfully, within those 45 days, the family was able to come to terms a little bit on their own time, and were able to essentially pull the plug to terminate this the care. So what are some reflections that we have on Mrs. G? So because undocumented immigrants don't qualify for Medicare or Medicaid, it means they don't have access to long-term care or rehabilitative care at all. Undocumented immigrants are barred from many of the benefits that older adults heavily depend on, including the above, but also don't qualify for home health, homemaker services, and subsidized housing in a lot of places. But thankfully, our institution was able to gather our resources and work together to give some sense of equity and justice for the family, because that's something that we say, every family should have that ability to come to terms with that decision in their own time, because it's not an easy decision to make. So we had to use a lot of resources and a lot of coordination to even give that family, even just a mild sense of being able to come to that decision on their own terms. So another clinical case example we have is Mr. H. So he is undocumented and uninsured as well, 65 years old, has multiple chronic conditions such as hypertension, type 2 diabetes, which in medical terms is DM2, diabetes mellitus type 2, and also had early stages of Parkinson's. So due to lack of access to primary care and preventive care for his multiple complications and his multiple chronic conditions, he actually had not received any care for his Parkinson's yet either. No medications, no consultant, no nothing. It's just he was admitted for diabetes complications and was diagnosed with Parkinson's while an inpatient, but then wasn't able to access any of the follow-up care that was prescribed for him in his discharge planning. But essentially, he did enter in the hospital because amputations were necessary for his complications. But the patient essentially required home health and homemaker services because there was no way that he would be able to take care of himself, but he couldn't access them due to his insurance status. So we had to work collaboratively with his family to come up with a schedule for them to take care of him. We had to get a home health agency to negotiate to provide even a few visits. And we had to get volunteers from local churches that they were involved with to also provide additional homemaker services so that they could, so that he could have some sort of care. So again, undocumented individuals are denied the services they need to age successfully in place. And largely, health systems and the families and the communities bear the financial impact. So I put here, health systems must bear the financial impact, but really it is the families and the communities that bear the social and emotional and financial impact, whereas health systems are using a lot of resources to provide ethical care for these patients. So, and unfortunately, undocumented families have to rely on creative solutions to make ends meet. And that involves a lot of work with social workers to figure out how that's going to do. So essentially, if there's anything from these case studies that I can promote to you all as Schweitzer Fellows, as change makers, as social justice advocates in healthcare, is there needs to be some sort of structural policy solutions for these patients, because unfortunately it's only going to continue to be more and more of an issue. So we need to be aware of that as a healthcare institution and need to come up with some solutions so that these people don't fall through the cracks, because the only way that they can actually get the care that they deserve is by having fierce advocates on their side, which I hope all of you will be. So we're going to move on into talking about guidelines and frameworks for becoming an immigrant welcoming healthcare institution. So this is really a synthesis of recommendations created by the California Primary Care Association, the Illinois Alliance for Welcoming Healthcare, and, like I said, the cohort of fellows that I have had the privilege of working with through the Chicago Area Schweitzer Fellowship. So and all of these resources, as well as a ton of other resources, are available in the second handout that you all have. But I do want to take this moment just to say that a lot of times this institutional change aspect can be so daunting, but really you have the ability to do any of these things. So because of your being a Schweitzer Fellow, and because being a change advocate, and because of being a healthcare professional, you really do have the ability to make institutional change wherever you are working. So if there's one thing that you all leave with, it's kind of that inspiration that you are able to do that, because if a social worker can do it, and you know, that should inspire you that a lot of other professions and a lot of other individuals can do it. So we always say there's no such thing as just. You can't say, I'm just a social worker, I'm just a primary care provider, I'm just a nurse, I'm just an occupational therapist. There's nothing I can do to make this institutional change. I want you to leave today knowing that, you know, that's not true, because you absolutely can. You just have to be creative about it. So the synthesis starts off with internal protocols. So general practices is kind of broken down to general practices. So not collecting information that's not needed. So not retaining IDs. For example, a lot of times we're not even collecting people's social security numbers anymore, especially since like the Medicare doesn't even require it anymore. So we don't need to be asking for social security numbers when we don't need them. So if it's not absolutely necessary, don't ask for it. So you have to look at your intake forms and see what is information that we're asking that might make us seem unwelcoming. You can also designate private areas. So take steps to secure patient spaces by ensuring a reasonable expectation of privacy. This includes having security guards, welcome desks, other things at areas to kind of set the tone. This place is for community and for patients. It's not for, per se, immigration enforcement or police enforcement. So specifically, it's really important to designate enforcement liaisons and a protocol and a code for any time there is police or immigration presence at your institution. So I can go into a little bit more about this in a little bit, but I wanted to kind of graze over the internal protocols. Then also talking about protected health information. So this is honestly just a reinforcement of HIPAA. But a lot of times when we have administrators or authority figures asking us for information about patients, sometimes we tend to buck to authority. But we really need to know that HIPAA is behind us in our protection of the health information of all of our patients, including our undocumented patients. So it's really essential for employees to know that law enforcement officials do not supersede HIPAA. For example, there is a clinic that I know of that is very open about them serving a large undocumented population. So they've actually had ICE agents calling their institution, asking to know when a patient's next appointment is. And so thankfully, the front desk employees know not to give out that information. However, if someone were to say, like, I'm calling you from a federal law enforcement agency and I need to know this information right now, I'm sure a lot of people might buck to that authority. However, it's really important to give training to employees to empower them to know that this patient information is sacred and it does not supersede HIPAA. And then we also have to look at training and culture change in general. So becoming a welcoming healthcare institution is a continuous process. You don't get to say, like, okay, I've become a welcoming healthcare institution because we have this policy, that policy, or the other policy, and now we don't have any more work to do. So providers and staff have to be sensitive, aware, and welcoming to all types of diversity. So welcoming healthcare policies don't stop at just being immigrant welcoming. You also have to be LGBTQ welcoming, disability welcoming, and other, you just need to be welcoming to all sorts of diversity, including racial, ethnic, religious, sexual orientation, and making sure that, your providers and your staff at all levels are sensitive to that. So it really is a culture of your institution that's going to really push that forward. So that means that there's continuous training for staff that's necessary. But then this is where it also gets really uncomfortable, especially when you talk to your HR department about this. But there needs to be repercussions and training for people displaying unwelcoming behaviors. So we'll talk about that a little bit more in the case studies, because there is a case of an employee being very unwelcoming and saying something very out of culture. And so we are going to figure out what's an appropriate way to address that. So, but just doing that home, driving that home, that becoming a welcoming healthcare institution is a continuous process. And also, you'll notice that there are a lot, and I mean a lot, of aspects to becoming a welcoming healthcare institution. And each one of them is a huge process. It's not easy to do institutional change, but it's a matter of prioritizing what you think is most effective for your patients and possible in your institution and moving forward with it. So, and this is kind of the icing on top, honestly, is creating an integrated rapid response team. So for patients that do have interactions with immigration or with law enforcement, the healthcare institution should be able to respond with legal resources, connection to local community resources, and they should be able to notify local community-based organizations of legal activity to appropriately organize and inform them. So these open collaborations between healthcare institutions and community-based organizations such as community organizers, activist organizations, social service organizations help break down barriers and help decrease false reports. So, for example, we see in Chicago all the time that there is a company that has white trucks, and I can't exactly remember what the name of the company is, but their acronyms for the company is ICE, so ICE. And so they would get reports all the time from community-based organizations or from activists or over social media, over Twitter, of people saying, "Oh my gosh, ICE is in my neighborhood. They have they have a truck. They're looking for people." But it's really important for healthcare organizations, community organizers, community-based organizations to really be communicating about this so that you can diffuse that really quickly. So it's really important to know if there is any sort of ICE activity on your healthcare institution that you would be able to appropriately organize and inform the community about that. And then you also need to be conscious about your messaging to patients. So I'll talk about the next couple slides, different signage. So there are signage for knowing your rights and signage that all are welcome. Then there also need to be training for staff to be reassuring of those policies. So if you do have policies to be a welcoming healthcare institution, you need to also be able to train your employees to effectively communicate those policies. So to be able to reassure patients, to be able to have messaging on hand, to work with their patients and to talk to others about these policies, because the policy changes don't necessarily work if it's just from a top-down perspective and you're just expecting people to read their emails, you're just expecting people to know what the policies are. You really have to work on a grassroots basis to organize within your healthcare institution to make sure people are informed and empowered about these policies and they're able to work effectively with their patients. So it's also really important to have materials in the admissions packet and your patient bill of rights, flyers around the healthcare institution that kind of reinforce that you're in a welcoming policy. However, a caveat to this is that it's really important that you're not saying, oh, like, these are your rights here, all are welcome here. You don't have to worry about ICE or immigration enforcement here if your policy is not actually in place. So the signage comes after the actual policies and the trainings and the cultural change efforts happening in your healthcare institution. You can't just put up a sign that says all are welcome here, but you haven't done any policies to actually to precede that. So that is kind of my one caveat to this, to welcoming signage. It's nice, but it has no meat if it's not actually in place and implemented yet. So as I promised, here are some, so these are Know Your Rights documents. So this one on the left that says what to do if ICE comes to your door is from United We Dream. And the right is from iAmerica. So these are Know Your Rights documents that you can make available for patients. You can get them to social workers, nurses, medical assistants, occupational physical therapists, anyone, or even have them in clinics available so that people can take them and know what their rights are. And then you have these kind of signs, which are for your institution. For example, like everyone is welcome here. Or I really love this one from Erie Family Health Center, which says, thank you for trusting your care with Erie. Gracias por confiar en su salud de Erie. And it just says, everyone will always be welcome here and treated with dignity and respect. And it has, a really diverse kind of cartoon thing because they didn't believe in, and honestly, they didn't believe that, a stock photo of diverse people would be okay. And I agree with them. Try to avoid using diverse people stock photos for your signage because it just is a little cliche and actually makes it a little worse. So here is what I was kind of telling you about how you had the power to do this. So how do you become a welcoming healthcare institution? So thankfully at Rush, we were very fortunate to be able to form an institutional task force on immigrant health, because it was something that our institutional leaders were believing in and wanting. But thankfully we had, but those wants from the institution didn't come without pressure, to make that very clear. So essentially, there was a grassroots approach to organizing from within that led to Rush giving us the green light to form an institutional task force. So a group of students from Rush College of Nursing, Rush Medical College, as well as clinical providers such as social workers, occupational therapists, and nurses began meeting and we created a list of suggestions for what Rush could do to become more open and welcoming to undocumented patients. We then presented this list to the chief medical officer, and to our huge surprise, the chief medical officer said, well, all of these sound great, but who's going to do it? Because most people who have the power and ability to immediately make these changes don't have the time or may not even have the interest in actually moving these policies forward. So we received the blessing to create a formalized group to work on medical center initiatives, and 2 groups were formed. So the 2 groups that were formed were one for the university side and one for the medical side, because Rush University Medical Center is a university, but is also a medical center. So we created a group for the university side, but I'm actually going to be speaking just to the medical center side. So first we had to establish what is the purpose, what is the working style, and what are the objectives for the group. We said that we wanted to have actual policy and then implement practice changes. We didn't want to have reports or statements that would just be sent out to people's emails, be printed out into a bound document and collect dust, to be sitting in someone's folder on their desktop. So we wanted something that actually had feet on it. And it was important to make our connections with other organizations doing this work through collaboratives and committees. So that is kind of tailed back to our work with the Illinois Alliance for Welcoming Healthcare. We needed to work with other institutions that were also doing this work and say, how are you doing this policy? What experiences are you doing? What verbiages are you doing? What are you implementing into your trainings? And then also reporting back to those other people doing that work as well, so that they could align our initiatives with theirs, and we could contribute our experiences to their initiatives. So the actual group, we brought in key change makers in different departments, but it wasn't enough that you have to be a change maker. You also have to care deeply about immigrant health. So that was kind of what we decided. In order to be like a part of the committee, you really had to care about immigrants, but also had to be in some sort of position where you could be a decision maker or directly influence a decision maker to make changes in these areas. So we recruited people from patient finance, patient access, legal and risk, population health, human resources, philanthropy, inpatient and outpatient social work, primary care providers, nursing, even our Alzheimer's Disease Center, palliative care, endocrinology, community engagement, and then also the College of Nursing and students from the Rush Medical College. And so it was also really important for us to have committee members from outside community-based organizations that were fully integrated into the committee, not necessarily just being there as guests, but really integrated as full members with full power, and them being there to kind of give us their perspective on the policies that we're moving forward, and to make sure that the folks that were actually impacted by these policies were represented in the decisions that were being made. So, as I said, becoming an immigrant welcoming institution is a never-ending task. So these are all different projects that immigrant health task forces or working groups, whatever you want to call them, can take on. But because this is all on one slide and they are, just little bullet points, it makes it seem like, oh, this should be easy to do, but each one of these bullet points is actually a huge institutional change area. So again, I'll just kind of reinforce, it's up to you, your organization's administration, the patients, to figure out what is the priority here. So like we said, a warrants and police presence policy. So trying to figure out that if someone if immigration and customs enforcement were to essentially go against the sensitive locations policy and try to question or detain a patient who's at your facility, you need to make sure that you have certain policies in place to make sure that those patients are protected to the full extent that your institution is legally allowed to. So that's what we did at Rush. The policies are publicly available. through the Illinois Alliance for Welcoming Healthcare. So you can actually get that from your resource document. You can see what is the verbiage that we put into it that actually kind of formalized our policy on this to make sure that all of the welcome desk people, security people are all empowered to say, if someone comes looking for a patient, we have every right to call security. We have every right to check their paperwork, their warrants, paperwork, and everything to make sure that they actually have the right to see that patient. And if they don't, we have every authority to escort them off of our premises and tell them not to come back, and to even call the police to have them removed if necessary. And then also a concept that most people are familiar with, but maybe not everyone, is charity care. So charity care is typically an institutional fund that's used to cover medical expenses for people who can't necessarily afford it. And so we really need to make sure that if you have a charity care policy, that it's actually being open and available and accessible to undocumented patients as well. And then we'd have connection to supporting and referring to federally qualified health centers. So federally qualified health centers largely, and I say largely because I'm not sure about every federally qualified health center, sees all people regardless of immigration status or ability to pay. And so a lot of times as an institution, we may not have the ability to take on all patients, but we also can't dump these patients onto federally qualified health centers. If we are referring to federally qualified health centers, we need as an institution to make sure that we are actually supporting with staff time, with resources, and with money for these federally qualified health centers if our institution is depending on them. So that's where it gets to more of like an equity lens as well. And then also formalization of protocol for medical repatriation, community outreach to promote equitable access to charity care, competency training for all staff and providers, and then, like I said, continuous dedication to a welcoming environment, contracts and riders with long-term care providers. So essentially, kind of with Mr. H, and Mrs. G, we really had to negotiate with long-term care providers to be able to get some sort of access to care. But it's actually within a healthcare institution kind of being able to swing their weight and their influence around for equity, to actually put it into contracts and riders with preferred long-term care providers of saying, we need you to take on X amount of our uninsurable patients if you want to remain our preferred provider for nursing home care or for home health. And that's actually something that Rush has successfully been able to do, is we've kind of held our preferred providers kind of to the fire about it and said, you make a lot of money being our preferred provider. If you want to continue being our preferred provider, then you need to at least take some of our patients who are uninsurable. And that has been a huge accomplishment, and it's been able to help us get some people into long-term care. And unfortunately, that's kind of what it's falling back on until we can have some sort of societal structural help with that. And then also training for providers on appropriate chart documentation. So that's also kind of just reinforcing what we all know, is that a patient's chart is their property. So they have the ability to see that chart whenever they would like to. It's their right to see those charts. And so we need to be able to document sensitively and appropriately in that chart. And it will make patients really uncomfortable if you specifically document their undocumented status. So you have to figure out what's best for you with your patient on documenting undocumented status, because you also have to take into account that everyone on their care team can see their chart. So if you write down that a patient is undocumented in their chart, you outed them to the rest of their care team. And coming out as undocumented is a very individualized approach. So it definitely is a conversation that you need to have with your patient before you appropriately document that in the chart. So we've gotten to the case study part, which is great. So for now, we're going to do kind of a role play. So we have a few different case studies here. So this is a lot easier to do when you're in person, because you can work together and you can put your heads together. But just think that you are the chair of your institution's immigration task force and come up with plans of actions of how you would address the case. So think about how your task force would respond. So there's two big questions here. What would you do in the moment to address the issue in the moment? And then what would you put in place to keep this from happening again? So we're going to go through each case study, and then we'll have some sort of time for responses and for ideas. And I know that we're not giving you much time to actually think about it. So really, it's kind of testing your ability to think on your feet as well. So our first case study is Community Health Center ABC is a federally qualified health center that has operated for many years and has a number of locations. The particular health center calls 911 to transfer a patient to a local emergency department because the patient was extremely hypertensive and needed to be admitted to the emergency department. So when the local paramedics arrived, they were accompanied by the local police. The police requested the Social Security card or other proof of citizenship for the patient waiting to be transferred to the emergency department. But when the nurse manager refuses and states that these documents are not necessary and are delaying the transfer and therefore endangering the patient, the police threatened to arrest the nurse, stating that she is interfering with police duties. So now we're going to actually kind of come at you with these questions. So what would you do in the moment? And what would you do to prevent this from happening again? So this is where I want to hear from you all in the chat boxes, as well as I'm not sure if I can actually unmute you. I think you have the ability to raise your hand, and I can unmute you if you do want to say something. So I can take about 3 or 4 people, but really anyone can type in the chat box as well. I know it's a big deal to think about right away, but. Okay, give you guys a few minutes to think. All right, so Ray, you have your hand up. Let me see if I can unmute you. Yes, go ahead, Ray.
Okay. Can you hear me?
Yes, Ray Reader, go for it.
That's me. Oh, Lord. So I think this is kind of a sticky situation. And we were talking in our little group, and we feel like this actually happened to someone. I think one of the things here, I'm hoping to be a primary care physician who works at an FQHC. So I really think about what I specifically would do in this situation as kind of the leader of the care team. I think, again, reminding that is not part of policy, that's not part of the law, that's not something that you have to give out because of HIPAA, which is this information that goes under that. And then I think kind of moving forward to kind of create more protection and stuff, even stating that that's within the rights, perhaps in a material that's present within the clinic, like a poster, or I know in lots of rooms in a clinical examination room, you can have some of that information up about knowing patient rights. Mm-hmm. And I think stating that you don't have to give these things under the law is important.
Yeah. Okay, great. Exactly. And then, oops. Okay. All right, we've got some feedback, so I'm going to put you back on mute. Okay, there you go. Thank you, Ray. All right, and then also have some things from the question box that says, find out what would even trigger the police to even flag that 911 call. Why did they even show up? So thank you, that the participant who said that. As well as the nurse in this situation, I would state that under HIPAA, I'm obligated to adhere to patient confidentiality. So, all right. Are there any other people who would like to comment on that? So, All right. I'm trying to navigate the chat box and the question box and everything. So let's see. All right. So essentially with this case study, this was something that actually happened. And thankfully, the director of the healthcare institution was actually close friends with the mayor and was able to call up the mayor directly and the mayor was actually able to get the police to back off. But that's unfortunately what had to happen in that sense, because the police were really adamant that they were not going to let this undocumented immigrant be transferred, which totally doesn't make any sense. But also we needed to figure out what could we do to prevent this from happening again. So it really was kind of the police presence policy and making sure that we were kind of that the health center did actually try to figure out why were the police even coming and why are they asking for this. So it was a matter of also having the relationship with the police department to figure out like why are they doing this and to figure out how they can prevent that from happening again. So it had some leaders meeting with some providers as well. All right, next case study. So XYZ Hospital Medical Center is a large hospital with more than 750 inpatient beds and over 10 floors. So each entry into the building is staffed with a welcome desk and a security guard. On a Tuesday afternoon, 3 armed local police officers in uniform walk into the building, walk right past the welcome desk and the security guard waving politely. The welcome desk sees that the 3 officers have gone up to the elevator on the 8th floor, which is inpatient cardiac care, and notifies the house operations administrator. When the HOA asks the welcome desk attendant what the officers were there for, the attendant says they didn't ask because they didn't want to question the officer's authority. So again, what would you do in the moment if you were that HOA, or if you were on your your institution's task force? What would you do in the moment, and what would you do to prevent that from happening again? Let's see. You can raise your hand if you want to talk. Okay. Questions. Oh my gosh. Let's see. Does anyone have their hand up? This is really my approach to try to make this webinar more interactive, guys. Let's see. Yes. Thank you, Jessica. You can also type your answer into the chat box, or you can raise your hand and we will call on you. All right. Mary, I'm about to unmute you, so hope you're ready.
All right, can you hear me?
Yes.
Okay, cool. So I work on acute care in a large hospital in Tulsa, and we have an interesting policy as far as visitors go. Like, you're not questioned when you come to the hospital. You're not questioned when you go into a patient's room, ever. And so I think that's good for families and stuff. They don't want a bunch of questions when they're going to see a sick loved one. However, I feel like if cops came to a floor, the nurses on that floor would be interested in knowing what's going on. And a lot of times we'll have inmates in our hospital as well. And so if there's a known inmate on the floor, maybe they wouldn't be stopped and asked. However, I think it really depends on, like, it would be a hospital policy for every visitor to be asked or to check in at the front desk or something like that. And I don't know if in a 750 inpatient bed hospital, that's really a good approach as far as just like the staffing required for that. In my mind, this kind of falls on the HOA, house operations administrator. Would that be like a floor supervisor maybe? or like the nurses for the actual patient to be aware of the policies in place and kind of advocate for their patient. Okay, put my hand
All right,
down.
great. Thank you, Mary. All right, yeah, so anyone else? Any sort of ideas? Like, what would you do in the moment? What would you do as a preventative measure to keep it from happening again? Because Mary made a great point. It is really difficult for like this huge medical center to make sure that they know the whereabouts of every patient, of every visitor. But at this particular medical center, it actually already is a policy that like every patient and every visitor has to check in at an info desk and get a visitor's pass that says like where they're supposed to be. But what we found was that at this medical center, the welcome desk still didn't feel empowered to question the authority of people in uniform. They said, well, of course they're supposed to be there. Why wouldn't they be there? You know. So any questions? All right, I'm not seeing anything in the chat box. Not seeing, I don't know if I see any hands up. Hands up. All right. All right, and so I got something from the signage desk. So clear signage at the front desk stating the policy that all visitors need to register first, including law enforcement, would be helpful, as well as training for the medical center staff about being assertive. And then, so thank you, Ray, for that, absolutely. And then for the future, you would definitely need to reinforce and empower front desk staff and security, and do that through training. Absolutely. So essentially that is what happened. So essentially what we did was the HOA immediately went up to the 8th floor to figure out why the officers were there. And it turns out that one of the officers that was on duty, they had a family friend who was in the unit, and so they were literally just going to visit them. But it also still took a conversation with those officers that, hey, just because you're a police officer, just because you're in uniform, doesn't mean that you don't have to stop by, doesn't mean that you're excluded from this policy. You still have to check in, you still have to get a badge, we still have to know why you're here. And then they had the opportunity to explain the policy. So it ended up being okay because they weren't there to apprehend a patient, but it was a little bit of that kind of working our relationship with the police to figure out that, you know, that they knew that this is our policy and we really need to implement it, you know, regardless of like what institution you're from or the reason that you're there. So, all right. Just want to see one more. So perhaps this also illustrates that the training of staff could include not just reviewing the policies, but also role-playing so that they can practice. That's an awesome idea, Kristen. Thank you. All right. I'm actually getting the hang of this webinar, guys. All right. Know how it works. All right. So the next case study. So I have more of these, don't worry. So the Academic Medical Center, ABC, has a contract with Immigration and Customs Enforcement that agrees the hospital will take in ICE detainees that become sick while in detention and need a higher level of care. This is actually something that happens pretty frequently, y'all, so you'll see this, especially if you live in a city and work in a city where there is an ICE detention center. So currently a 48-year-old female patient detainee from Central America is in an inpatient unit for heart failure. 4 ICE agents are standing guard of the patient. So over lunchtime, the ICE agents head down to the hospital cafeteria for lunch because they're also human and they need to eat. And they're in full uniform. While in the lunchroom, a table of students, including an undocumented student, sees the ICE agents in the cafeteria and become fearful and confused. These students then come to your task force with the following concerns. The fear that undocumented students, patients, and visitors would have if they saw the ICE agents there. Why were the ICE agents even there? And what can be done? So similarly, what is something that you could do in the moment to address the concerns for the students? What's something you could do in the moment for the ICE agents who have probably been long gone by now? And then also, what is something you can do to prevent this from happening again? All right. Checking to see if anybody has their hand up. Anybody in the chat? Nope. Yeah, there is really no wrong answer here, y'all. So, okay. See. Do we see any hands? Any chat? All right. So I know this is a difficult one, yo. So, anyone want to take a risk and suggest something? Ooh. Let's see. Oh. Yep. Request. Oh my gosh. Why is this not working? Oh, there we go. Now I can get it. Okay. So thank you, Akana. So could there be a hospital policy to have plainclothes agents or to eat in the patient room? And then also from New, request that the agents cover up their uniform and suggest that they order their food up to the floor. And then we do have a hand raised. All right, Tim, you are unmuted.
Okay. We have controlled that issue with echo there. Yeah, so this seems in some ways like a situation that you could also have with the police officers we were saying kind of in our little Tulsa group here, where the presence of someone in uniform, you know, whether that's ICE to an undocumented immigrant or whether that's a police officer for somebody, a patient, perhaps with a warrant out for them, creates, you know, fear. In this hospital situation, it sounds like there is a good policy in place that respects the rights of patients. And that's not the problem. The problem is the perception of, you know, other patients or visitors in the hospital of the presence of these ICE officers. And so maybe a solution would be for the hospital to adopt a policy wherein they have, you know, in these situations that they know are going to happen, where they have ICE officers or police officers, those officers be in the hospital in plain clothes rather than in uniform. Then you can still have enforcement of policies, and you can still have officers who can go down to the cafeteria and aren't locked up in a patient room, but not have unwarranted fear on the parts of, you know, other patients and visitors in the hospital.
Okay, absolutely. Thank you for that. All right. Does anyone have any other comments or questions on this? But yeah, so that's exactly right. So you guys are on the right track. So you're actually on the right track, same track as the task force was. Is, you know, how can we do that? Because obviously, this is a partnership that the medical center wanted to continue, and we still need to be able to care for people in ICE custody when they need this level of care. So unfortunately, that's just kind of how the institution runs, is like why they needed 4 ICE agents for a 48-year-old woman with heart failure is beyond what any of us thought was necessary. But, you know, hey, that's a whole different conversation. But yeah, that's essentially what we're trying to get into. So that's essentially what we were trying to get to, is what are some ways that we can reduce that fear since unfortunately the ICE agents being there are is kind of something that we can't really avoid. So that is exactly what we said. We said they have to be in civilian clothes. They cannot be in uniform if they want to venture to other parts of the medical center. And if they do, we have the scrubs that they could put on and wear if they wanted to leave the patient care area. So that was essentially the policy that we're trying to put in place at this institution. Because I'm not saying it's rush, but so these case studies could be at any institution, not necessarily just at Rush. So just wanted to give that a heads up. But another person from the chat, Ray, said a code word for students to let them know that ICE is in the building, because the students still think that they're at risk if ICE is there, even if they are in plain clothes. That's true. So ICE hasn't been known as the kind of most focused or ethical agency, which is why a lot of people are being led to wanting to call for them to be abolished, actually. So so that is another thing to have to deal with. So that's actually a really great idea, Ray. Thank you for that. So essentially some sort of messaging system that goes out, like if there is ICE agents on the premises, to let people know and to know why they're there and where they will be. So it's both a matter of keeping the ICE agents isolated to where they absolutely need to be, making sure that they're saying, so something that the nurse floor manager has offered, and it's really a big deal for a nurse floor manager to do this. They said, we don't want you going down to the cafeteria. We'd actually rather go get food for you and bring it up so that we're not, so that people don't see that you're here, because we're trying to be a welcoming healthcare institution. All right, so let's move on to the last case study. So a community activist in the Arabic community is admitted to the hospital for hypoglycemia and notices on her wristband next to her name, it says legal. Although this is meant to indicate the patient's legal name, when the activist asked her bedside nurse what is meant by this, the nurse explains, "Oh, that means you're a legal citizen." While the activist actually is a U.S. citizen, she becomes concerned that the hospital is categorizing patients based on their immigration status. The activist then tells the story across social media, and it starts to create a lot of buzz. The story eventually makes its way around, and your community connections at a local CBO alert you of the incident. All right, so what can you do in the moment, and what can you do to prevent it from happening in the future? So you all should be used to this format by now. All right, Jennifer. All right, I'm going to, Jennifer, is your hand still raised? Maybe you can post in the chat box. I'm sorry, I didn't see that you're, okay. All right, Rachel.
It's okay. Yeah, I think you can talk.
Hello, can you?
Yes, Rachel, you're unmuted.
Say it's Olivia.
This is Olivia. I'm on Rachel's computer.
Okay.
So I think one thing sort of in the moment is you certainly want to address the news breakout to let potential patients and the public sort of explain what was going on, that you're not in fact categorizing patients and putting it on wristbands. You have to do some damage control there. But then I think going forward, I think this is one instance of looking at like language use throughout the hospital and making it a more immigrant welcoming institution. And I'd be interested to have, even welcoming that activist back or activists from other communities to even maybe sort of do like a walkthrough as a patient and sort of see if they're able to identify areas that maybe the task force in general wouldn't even realize would create distress or miscommunication in healthcare. So that's one thing that you might be able to do going forward.
All right, awesome. Thank you. All right. Does anyone else have? All right. Thank you, Jennifer. Immediate statement directly to social media and news outlets is important nowadays. Absolutely. All right. So you can use the chat box, questions box. You can raise your hand if you would like to just be unmuted. Okay. But yeah, so essentially this is an incident that actually did happen at an institution, and yeah, it created quite a buzz, and the community-based organization was like, wow, can you look into this? So this kind of led to what I was saying a lot earlier in the presentation, where we really need to make sure our welcoming healthcare institution is a cultural change, to make sure that people are more sensitive to the words that they're saying and how they're communicating with patients of varied and diverse backgrounds and immigration statuses. So, and it's a matter of making sure that you are actually able to identify when staff and providers are being unwelcoming, and having something in place to be corrective about that and to have consequences. So essentially what the institution was able to do was through the patient, we were able to identify who the nurse was, and we didn't feel like it was appropriate to single out the nurse, but we did talk up to the unit and provided education for the unit to let them know that it means legal name, and that also to do some sensitivity training around immigration status, and to kind of let them know that this was kind of the repercussion of their unwelcoming behavior, was that it did create kind of a media slurry for the institution. So, and that's something that every institution needs to focus on, is like, how are they going to address when something is being unwelcoming, and especially being restorative about that. So taking a restorative approach to unwelcoming behavior and following up with, identification and education instead of being punitive. So, all right, Joe. So here are some reflections just overall from the webinar and from what we've talked about today. So it's interesting to see how different professions bring different perspectives to the table. So like I talked about with an institutional task force on immigrant health, it's absolutely necessary to have as many people at the table as possible to make sure that the changes you're moving forward are actually institutional, are actually thoughtful, are effective, and are actually implemented. So I believe that our training as Schweitzer Fellows really prepares us for that, because we have been trained in this interdisciplinary interprofessional work. So it's very, very important. I feel like being Schweitzer Fellows really puts us in that skill set to really lead these social change initiatives at an institutional level. And so do you think it was necessary to have different professions and positions represented to create a thorough intervention? Is that something you think is necessary? How do you think it's necessary? And then also, how do you feel your Schweitzer training prepared you for an interprofessional task force? So these are some things we'd love you to reflect on. And then now we're going to open it up to overall questions and answers. So that's me. But anyway, I'm going to leave that slide off. So I'm going to go to the previous slide with the reflection questions, because it's just always really uncomfortable for me to look at a big old picture of myself. So, but that is my contact information if you would like to email me. And that is my office phone if you would like to call me to discuss anything. If you have any questions, you want my perspective on something, or if you just want to learn, what are some specific strategies, or want to consult about something with your own institution, would be really more than welcome to do so. So just going back to the reflections page, would love to hear about questions or reflections that are related to this. So I will open it up. So if you have any questions, go ahead and raise your hand here or post it into the question box or the chat box, and I'll go ahead and answer. All right. I'm seeing, is there anyone with their hand up for questions or reflections that they would like to share? All right, have some hands. All right, Rebecca, you are about to be unmuted. All right,
Sounds
go for it. You're unmuted.
Hi. Well, thank you for this presentation. I think it's really great. I guess my question at this point is, how do we best, like as an organization, publicize the fact that we're immigrant welcoming? And then I guess my second part of the question is, how do we make sure that we convey to people who may not be in our organization but that will want to be involved, to also know that they can come to us and volunteer in whatever organization that we are in?
Mm-hmm. Okay. So one is, how do you let kind of the world know that you're an immigrant welcoming institution, but then also how do you let volunteers in who want to also be part of your institutional efforts, right?
Yes, that's my question.
Okay, great, awesome. So I would say for the first part of the question, which is, how do you let the world know? If you're making these changes on an institutional level, news outlets definitely want to know, so you can be very, and it also depends on your institution. So some institutions want to be very public with this. Some want to be public with kind of like the brakes on it, but some others may want to be totally quiet about it and just have it be internal. And so that is really, obviously, I'm very appreciative of organizations that want to be very public with it. And with that, I would say, social media, talking to media outlets. So at Rush, we were able to talk to NPR and do an interview with NPR. We were able to talk to Telemundo, Telemundo, Univision. We were able to talk to the Chicago Tribune, so newspapers. So we were able to kind of like get this information out there that we were kind of taking these initiatives to be more immigrant welcoming. And we also had to work internally with kind of our marketing department, with our charity care department, because there was a legitimate worry that that if we started promoting ourselves as this immigrant welcoming institution, would we be overwhelmed with undocumented immigrants who have no ability to pay, and would essentially put a strain on our charity care system. And essentially that was kind of a straw man argument that came from people in the institution, because we were just like, if our leadership was like, no, we're going forward with it. But there's some institutions that may not be, as down to be as public with that as we were. And so that's something that, that's kind of on an institutional basis. And then also that's where the advocacy and organizing from within becomes really essential, because you can really you can gather patient stories, you can gather provider stories, you can get people to sign on to letters, you can do petitions to try to get those initiatives forward, to get people to be more public about it, to say that like we want statements, we want newsletters, we want things that align with what our values are that we're supposedly doing. So that's where, it really becomes an institutional effort. but that's where the advocacy and activism from within comes into play. As far as getting people who are in the community that want to be involved in your efforts, it just has to be open. So honestly, we take our community representation on our task force very seriously. Like I said, our immigrant health working group incorporates community representatives from community-based organizations, and we represent them fully. They are full members. They're not like conditional members. They are respected as full members of the committee. They have equal say, equal power. They're invited to everything. They're on all of our emails, minutes, and that's where like we're incorporating them. And then a lot of times people don't want to commit, coming to your meetings and working on your projects, but you can always, have a newsletter, keeping people involved, and then also inviting them to your events, inviting them to press conferences, inviting them to trainings, inviting them to take part in the implementation of trainings. These are all ways that you can kind of keep your community activists involved that might be helpful. So, Rebecca, did that answer your question at all?
Yeah, you did. I think that was very, very helpful. Thank you.
Okay, awesome. All right. Do we have any questions from the board? Anything in the chat? No. All right, guys. Well, last chance to raise some questions. All right. So speak now or forever hold your peace. All right. So thank you again. I just want you to reflect on.
All right, so that is going to conclude our webinar. Thank you, Padraic, for sharing your experience and expertise tonight. I would also like to give a big thank you to Maya Bauer and Health and Medicine in Chicago for helping host this webinar, and the folks on the Fellows for Life task force that helped in planning and promoting this event. Finally, thank you everyone for listening and participating in this webinar. You will receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. You will also receive a survey on the presentation. We would appreciate it if you would complete that and provide your feedback. If you are interested in joining the Fellow for Life Task Force to help plan the next webinar or other national events, there is a field on the survey to enter your email. We will be having a conference call on February 26th, so you can contact one of us if you would like to be involved. Thank you again, and have a good night.